Dan. Thanks for taking time today. I really appreciate it.
My pleasure.
And when we sat down, I looked up. I'm like, wow, that's convenient. Right next door.
My old haunts.
Well, actually, you're the original. One of the original creators of that.
Well, it was around before, but
Right.
it was a different company.
Yeah. Yeah. For those that don't know, you were CEO of PVT, Percutaneous Valve Technologies.
That's right.
Came out of Israel, right?
Not really.
No. Where did it come out of?
So, well, it came from Cribier presenting to us.
Yes.
And, but you know, he had drawings and ideas, right? And so that's kind of the fundamental difference between an inventor and an innovator, right? The inventor has a great idea, but he needs innovators to actually make it into something that works, right? And that collaboration was spectacular, right? And Alain Cribier and Hélène Elchaninov, who worked with him, Stan and myself, were a great team in that. And we founded the engineering team in Israel just because we love those guys.
Yeah.
They did some early contract engineering work for us. And maybe a brief story on that was that, you know, I hate contract engineering. And I remember sitting down with the contract engineering president, and I said, Abby, you know, I don't like contract engineering. You have every incentive to run over, take more time. I train your people, and then I lose all that investment. And so we started hashing it out, and so I came to an agreement. Oh, and I said, you have no vested interest in the outcome. I said, none of that makes sense to me. So I struck a deal with him so that, number one, he broke even, he didn't make money, and in lieu of profit, I gave him options.
So you were
Right.
generous.
So he had a vested interest in the outcome,
Yeah.
right? Make it work.
Yeah.
Two, I said, I'm happy to train your engineers, but I want to call on them. And three, I'm going to fund this in milestones. So if you're not making it, I'm not funding it. So we did that for about a year, and then I exercised my call, this is a group in Israel, and I took his best engineers.
Well, I always say I never carry any bit out of a company in a black bag. They just choose to leave. If they see something on the other side of the street that really intrigues them, then they leave.
And they were fabulous and great partners along the way. But, yeah.
So then PVT made its way, Edwards acquired, moved out west, and you followed.
Yeah, so you know, I thought when we sold PVT, we'd only done, you know, a few patients along the way. And so it was early. And they asked me to join them for continuity, and I thought, well, maybe I'll be there a year and go do something else, right? And I ended up staying for 15 years. I loved working for Mike Mussallem. He's a great guy. It was a great team of people. And I became the chief scientific officer there, and so I was able to hopefully shape some of what their successes have been over time. And really a lot of what became TMTT was stuff that we were doing in advanced tech. So had a lot of fun there, but you know, at the end of the day, I wanted to work in a broader sense, right? Edwards was focusing down, and so I wanted to do, in my last years of working, I don't know when that'll be, but I thought, let me see if there's some paradigm where I can do something broader, and that's where we ended up founding Nidus Biomedical.
And I want to jump into Nidus. I do want to, though, as you walk around this event, it's fair to say Edwards was let's call it a creator of a category.
Yes.
For the most part. When you walk around here today, what do you see coming over the next 5 to 7 years in this category in particular?
Oh, in structural heart specifically,
Yes.
yeah. Well, I mean, the recent addition is not terribly recent, has of course been the LAA area, which is also a huge category within structural heart. I think we're just, the tricuspid is just really starting. I don't think the FMR's ever really caught on yet. It's not really penetrated. And despite the fact that the trials that were done, or I'd say the trial that was done, COAPT was, I thought, very compelling that FMR with heart failure is not an innocent bystander. That control group didn't do well, and yet I don't see the utility of treatment of FMR. It's not really penetrated heart failure yet. Maybe we need more studies. I think the tools are pretty good and the outcomes are pretty good. They're not perfect yet, but they're pretty good. So I think we have a ways to go in kind of the mitral and the tricuspid side. The only other category that kind of fits with this is heart failure, transcatheter heart failure. And for a long time, I thought that was kind of the next big thing. And, and I'm talking beyond things like pumps. How do we treat these patients? I was given a lecture the other day and talking about the ADHERE study was 2003, and it was focused on the patients that have acute decompensated heart failure. There's 1 million a year in 2003. So we've had a whole bunch of new drugs come in, new categories of drugs to help patients with heart failure. So that must be lower now, right? It's like 1.3 million patients.
Do you think that's because we're doing a better job of graduating patients to heart failure because of the advancements in structural, in the aortic, and even some of the mitral work? Are we just pushing them further down the therapeutic pathway eventually to become patients?
Great question, and maybe we are, and maybe it's just that we're surviving patients better from heart attacks, and we have many more patients, but actually I'm sorry to say that I'm not sure the percentages have changed that much, right? There's maybe 6.2 million, something like that, patients in the United States.
Well, it can't be lifestyle and diet and lack of exercise. It's got to be something else. Nobody wants to own.
We know it's not that, right? We don't have many vegans in that group,
Yeah.
but honestly, the percentage of patients that are still having acute decompensated heart failure is still about the same. Despite all these drugs, we still haven't solved that problem. And so we need to do better. I mean, all these drugs have improved things a little bit, but they're not keeping patients out of the hospital with decompensation. That's terribly disruptive to them. Yeah. And their quality of life not great with that condition. So I see that as a big area. I know Dan Burkhoff is now doing a great meeting in that area. But again, that's kind of the cutting edge. But I think that's a huge area for us to grow into.
So you were looking for a wider aperture in your later innings, as you called it. Tell me about NIDIS. You and I were chatting yesterday, and you said, I'm doing some great work here. I also want to continue to swing for the fences.
Yes, yeah.
What does that mean?
Well, this iteration of our incubator, and let's start with, there are two different kinds of incubators. One is the kind that kind of houses small companies and provides services. We're not that kind. We're the kind that we invent stuff, and sometimes we'll, if we have a great idea from the outside, we welcome that if it's really early and disruptive. And we'll take that through the early stages of feasibility, and then we will spin out that company. So we're that kind of incubator. We like to take things through those early stages. And we have now a series of build to buy projects that are kind of the core of our business. And then we have 2 swing for the fences disruptive projects. I can't talk very much about.
Can you say what general category? Are they in cardiac? Are they in?
Yeah, so our cardiac related. So one is a treatment for heart failure and other patients. But it's kind of, it's a better way to manage fluid volumes.
Okay.
And it's not something you've seen, like a pusher or a puller or completely different.
All
And
right.
then we have another project that is really interesting that's an alternative to plugs in the left atrial appendage. They're having real problems with leakage with these, and that increases the risk of thromboembolic events, and controlling, leakage is very difficult with all the devices. So we just have a completely different approach to that, which is really fun. We've always kind of believed, I have some of the best innovators that came from Edwards.
I was going to say, I'm sure some of the great ones followed you.
Yeah, so I've always believed that the job of a great manager is to hire people smarter than you, and that was really easy. Bring over these brilliant guys from Edwards, and I learned from them a lot, and they're fun to work with. I still have a no assholes policy, which works. It's fun to go into work every day, and I don't spend my time in meetings. I get to actually do work related to new stuff.
You mentioned build to buy, and we're starting to see more and more of these structured deals because the innovation seems to be creeping out of the large strategics. They just don't tend to attract and retain the greatest minds when it comes to innovating ideas.
I do a whole presentation, Joe, on why big companies can't innovate. And I really think it's about culture, risk-taking, and the ability to kill projects. Very simply, if you're a VC, you're a professional at selecting great projects. You talk to 200 companies, you select 10 companies for your portfolio, and you have one success. Why do you think a big company that's going to innovate is going to do a whole lot better? Now, they may be category experts, but if you can't kill projects, you can't innovate. So go to any big company and ask them, how many projects have you killed that were innovative projects? Not because you didn't have funding for them, but because you went through a learning curve and you decided, well, this didn't work well enough. That's okay. Kill that project. They don't have the culture for that. And that's what it takes. It takes a culture where you can kill projects, you can take risks, and they invest in the things that are predictable. Here's the budget, I can follow that budget. Here's our timeline, I can follow that. And what are those? Those are iterative projects.
Yeah.
You want to do something really new? Doesn't really fit in the corporate culture. And that's good for people like me because I want to do that innovation for them, and they can buy it. They pay more, but they take less risk. And I think that's really the way ecosystems work. I tried to do innovation at Edwards, and I think we were pretty successful for a while. But I think the bigger they get, the harder it is to do that kind of internal innovation. And so I think Edwards and other big companies are now just focused on external innovation. And those build to buy projects, to get back to your point, are fantastic because a lot of them are, I think that structure is designed so that you can do it off the P&L.
Yeah.
So they can concentrate their their R&D dollars on iterative stuff and stuff that they buy and they have to invest in the clinical side. And that, I think that makes, I think that's a good ecosystem
And
for
the
our
entrepreneur,
industry.
it's good too, because they know they've got an acquirer on the back end.
Yeah.
They generally don't have to worry about fundraising. They allow the structured partner to see under the hood. Let's use their QA system. Let's use their clinical team. Costs me less money to get to the finish line, versus being an entrepreneur. It's like, I built this great product and I hope there's a buyer for it.
Right.
Everybody wins.
And I agree with you entirely, and I think a lot of this is I can agree upon a product definition, performance criteria, and when you meet this level of performance, I have a call, right? And if everything goes well, if everything's stable, they should buy you. And I think when you do these, the only nuance is that you need an exit strategy if it's not that company. That you probably need to say, well, look, if you're going to walk away, you need to put a couple of $1 million in, $2 or $3 million to enable us to go find either someone else who will buy us or an investor to take us to the next step.
Yeah, so there's a little put, little call. Everybody gets covered. And that governance, I've been having a lot of conversations around that governance too, the definition, because we've seen in recent news, some of the big strategics have very poor governance in a build to buy, and it cost them a couple $2 billion. So I think we're going to see more of that. We have to see more of that, or otherwise innovation gets suffocated.
Yeah, and I think, at least the way we try to do it is, we just see them as development partners. I don't want to just be reporting to them. I want to be asking them questions, right? Here's what we plan to do next. Could you give me some input, right? And so really treat them as partners, and I think if you respect that relationship in that way, that I think your chances of being acquired will be better. And I'm a firm believer, just as I was with PVT, that the company that you're selling, or the technology you're selling, and the company that's buying should both benefit. That's the win-win that feels good to me. I've seen lots of people sell stuff that sat on the shelf, and at least I wouldn't feel good about that.
Every innovator wants their product to make it to the patient.
Yeah, and help patients.
Help
yeah,
patients.
Something they can be proud of. Yeah.
Well, Stan, I really appreciate your time.
Always enjoy it, Joe.
The privilege is mine to have you chatting with me.
Thank you so much.
Thanks. I'm Joe Mullings, TCT 2024. Be well.